Good morning. Hello, I'm Ken Wells on the Psychiatry Department, and I'm happy to introduce our speaker today, Harold Allen Pincus, MD. Harold is Professor of Psychiatry and Healthcare Management and Policy and co-director of the CTSI at Columbia University and New York State Psychiatric Institute. He's the National Director of the Health and Aging Policy Fellowship and Senior Scientist at the RAND Corporation. He was previously director of Rand University of Pittsburgh Health Institute and executive vice chair of the Department of Psychiatry at University of Pittsburgh, deputy medical director of APA and founding director of APA's Office of Research, and special assistant to director of NIMH. Dr. Pincus has been on editorial boards of 12 journals and has more than 500 publications with an H-index of 99 in health services research, science policy, research career development, quality of care, and diagnosis and treatment of mental disorders. He was co-chair of the Measure Applications Partnership under the Affordable Care Act and of WHO's International Classification of Disease ICD-11 Committee on Quality and Patient Safety, and vice chair for the task force on DSM-4 for APA. Dr. Pincus has received many awards, including the Menninger Award of the American College of Physicians, Research Mentorship Award from the American Association of Chairs of Departments of Psychiatry, Westermark Award from NIMH and APA for contributions to psychiatric education, Emily Mumford Medal and 2019 Mentor of the Year at Columbia. He has worked for many years at Public Mental Health Clinic, caring for patients with severe mental illnesses. He and I met our first year together in the Clinical Scholars Program and have been close friends for 45 years. Welcome, Dr. Pincus.
Well, thank you, Ken. I'm delighted to be here at UCLA and look forward to engaging with everybody about some of the sort of more controversial policy issues that are beginning to come up. So let me just note my disclosures, outside activities in terms of my source of research support and consulting relationships. So what I'm going to be talking about today is about the whole movement towards value-based payment that's going on in terms of our overall healthcare system, a move away from fee-for-service and towards value-based models. And there are major barriers from the point of view of behavioral health to actually integrate the behavioral health system into a value-based payment program. And these are the top 10 that I mentioned. I'm going to go through them one by one. But it starts with the fact that value-based payment is not really well understood. We have pretty lousy behavioral health quality measures, which are an element that's needed to be part of value-based payment. We've had a lack of investment in measure development. We have a difficulty in siloed data sources in terms of being able to gather data. There's been a problem for a long time in terms of the ability of behavioral health entities to actually have adequate and useful EHR systems. And there's also the problem of risk adjustment. And then once you actually do have a system in place, how do you actually take action to improve outcomes is a complicated process. Also complicated are some of the limitations in doing that come up with regard to our limitations in the behavioral health workforce. And then basically overall, once you get engaged in value-based payment, that the incentives are often too small to change the behaviors of organizations. And finally, the assumption that by providing more behavioral health will lower direct healthcare costs may be overly optimistic. So just a little bit about what is value-based payment. So this is really something that is a definitional kind of thing, but basically, in contrast to the predominant fee-for-service model in which payers reimburse providers a fixed fee for each service, they provide an approved list of value-based payment models holds providers financially accountable for both the cost of care and also the quality of care that they deliver. And this concept of value-based payment is an important element that was introduced through the Affordable Care Act. We'll talk more about that. And so when you think about it, these are the Healthcare Payment Learning and Action Network is an organization that's been put together to try to implement and help facilitate the development of value-based payment models. And they have these different categories. First is the category 1, which is fee for service with no connection to any kind of quality measurement or incentive. And then category 2 is where there is a fee for service kind of process, but there is a way to actually add some kind of incentive for performance. And so, for example, the MIPS program under Medicare. Category 3 is when there's a larger type of value-based payment model that has been put in place, typically for primary care or for overall health care, that hold providers accountable. And oftentimes this is completely under the auspice of the payer, the health insurance plan. And category 4 is ultimately having a fully capitated system where the incentives are based around being more efficient and having higher quality. And so we'll talk more about how this comes into. So the problem is that we really have a problem with people understanding what it takes to become a value-based payment model. There are distinctions between the different payment mechanisms, whether it's bundled and capitated services that are put together, under a fixed capitated price, versus fee for service being paid by each action, each service that you're providing. There are also different ways in which accountability is assured in these processes. There are regulatory processes in terms of meeting certain accreditation requirements. And then there may be fixed quality measures, as well as financial incentives that are built in to encourage more efficient delivery. And all of these all the different models have different degrees of flexibility, complexity, identification of who's responsible and who really controls what the actions are. But the basic definition in terms of value-based payment is basically the equation of value being quality over cost. And you need to measure each of those variables. So there are full risk versus more incentive-based kinds of programs where it's you get either a penalty or a bonus if you do well or poorly. There are structural or recognition programs that are more if you meet certain accreditation standards, like a patient-centered medical home, you get a bonus for that, and it's sort of built in some of the payment parts of it may be based upon your performance. Then there's pay for reporting, where you don't get a bonus based on actually having results or outcomes, but you actually get paid for more reporting. And I'll talk a little bit more about that. And then there's finally pay for performance, which is ideally what is hopefully going to take place. There's also an important role of risk adjustment that I'll talk a little bit about in terms of how you adjust for the severity or intensity of the population you're seeing. And then there's how the quality measures are selected. Are there a required set of measures, or do providers or payers have options that they can choose which measures they want to use? A lot of these apply beyond behavioral health, but there are some really specific problems in the behavioral health area where there are real barriers to implementing value-based payment. So the biggest issue is the whole issue around actually developing quality measures. And most people tend to think about this from the Avitas Donabedian model of structure, process, and outcomes in terms of the categories of different types of quality metrics. And the problem we have in behavioral health, and this is sort of the number 2 barrier, is that we don't have very good quality measures. And for the ones that we have, we're not really performing very well. So we need to develop quality measures, but it's not so easy to do that given some number of the barriers. There are limited practical data sources that are routinely collected across behavioral health care. And in most cases, and this applies not just to behavioral health, but especially to behavioral health, a lot of the data that's used for determining quality are simply, the payments that that are being made by health insurance companies. And so actually, it's that an event happened. I had a visit, or I performed a procedure, but there's nothing about the quality of those procedures or what happened in the visit. So it's mostly process measures that are claims-based measures. So you can tell whether, for example, if somebody's discharged from the hospital, do they have an outpatient visit within X amount of time as one measure. There are pros and cons to those kind of measures. And when you actually look at it, a lot of these claims-based measures don't always have a definite association with outcomes. So that's another barrier. The other problem is if you look over the last several decades of the quality of behavioral health care, there has not been very much improvement. In fact, the performance has been pretty bad. And here's an example of that. So this is the latest National Healthcare Quality and Disparities Report, which is put out by the government. And this is a direct quote from it with regard to the chapter or the section on mental health and substance use measures. Among the core set of 9 measures, only one measure showed improvement over time, and that was depression treatment among nursing home residents. And that's really just looking at, did they get any kind of treatment, not necessarily the quality of it. All other measures were not changing, the 5 of them, and 3 of them, they were worsening, actually, over the recent time, especially the issue of suicide mortality among people aged 12 and over. So we're not doing that good a job in terms of actual performance. Here's an example of one specific, there are almost no specific behavioral health value-based programs, but there is one that's the Inpatient Psychiatric Facility Quality Reporting Program. And these are all of the measures that are part of the required reporting. The problem is, all it does is, the only penalty is if you don't report. You can report terrible results, and you still get paid. So it's, did you report or did you not report, is what this is based upon. So it's not very heavy incentive to actually improve things. And here's an example of just to see what's going on. Here's looking at the measure I mentioned before, follow up within 7 days after discharge from a hospital over the past, this 10-year period. And as you can see, on average, less than half the people who come out of a hospital actually have a visit, outpatient visit afterwards. And when you think about it, right now it's really hard to get into a inpatient unit. You have to be really sick. And the length of time, the length of stay is not much different from an MI. It's 5 to 7 days. And so you're then out back where you were, and more than half the people don't have a visit within 7 days. So there's very little follow-ups. Now, there have been several reports over the years about the need to improve the quality measurement capacity within our health system. This goes back quite a ways, Crossing the Quality Chasm report, which really laid out the need for more attention to developing quality measures. And at that point, it didn't single out behavioral health, but it did it with specific recommendations. But it did point out that there was particularly a problem in behavioral health, which then was followed up by a specific National Academies report focusing on mental health and substance use. I was fortunate to be a member of that committee. And there were a number of things that were very strongly recommended. And this was also followed up by another report that specifically focused on improvements and focus on psychosocial interventions and developing measures and ways of establishing evidence-based standards for psychosocial interventions. And this is a direct quote from the National Academy report. And if you look through it, and I'm not going to read them all out to all of you, but pretty much every one of these would still be true today. When you think about it, and that's one of the issues, and this goes back, 15, 17 years. So we have not made much progress in terms of addressing some of the barriers and capacities to actually respond to the challenges involved in value-based payment models. And part of it is that we have not really made a major investment in behavioral health measure development, either on the public government side of things or on the private sector. I mean, part of it is it's become a very complex process to go through the whole process of, I talk about it from the point of view of quality measurement industrial complex, because there's a lot of players involved in developing and identifying and then putting them into play. And I'll talk about that in a minute. If you think about it, NIMH and SAMHSA in the past have had no specific responsibilities around developing measures. And most of the measure development has been either at the Center for Medicare and Medicaid Services or on the private sector side. And part of the problem has been in the past that there's been limited behavioral health expertise at CMS. And so there's not been a lot of funding for the development of measures, but there has been some recent updates that are important. One is there has been a CMS work group on behavioral health that was established a year or two ago. And actually, I met with them and spoke with them several times. Number two is NIMH last year put out a funding announcement specifically focused on behavioral health quality, mental health quality measures. And third is that under the Biden administration, there was a strong set of initiatives around behavioral health. Including, I don't know how familiar people are with the proposed parity rules for actually operationalizing what was in the Affordable Care Act with regard to parity of behavioral health care. So there are some positive things in terms of the recent work being done in this area. But basically, this is the quality measurement industrial complex process. First, you have to have an evidence base on which you're basing the development of the measures on. And then you have to, showing that X, Y, or Z works from good, solid research evidence. Then you have to translate that evidence into guidelines in terms of what are you recommending that the behavioral health system does. And you might say, so the example was follow up after hospitalization. That's a nice concept that you want to have followed, but how do you operationalize it? How do you operationalize both the denominator and the numerator of such a measure? When you're thinking about it, so what counts as a visit? Does it have to be face-to-face? Can it be remote? Does it have to be with a certain type of professional? What length of time is appropriate? But also the denominator. Is it anybody who's been hospitalized? Can they have been hospitalized for one night? Can they, what's the definition of, a discharge? So you have to operationalize that from both perspectives, and then you have to test the measure. It actually goes through in order to go through the endorsement process. It's kind of like almost like a NIH review committee. There are certain criteria that have to be applied. Among them is its scientific acceptability of reliability and validity, but also it has to be an important issue. So importance is a factor. In addition, there has to be a feasible way to gather the data, so it doesn't cost a lot of money to actually gather the data. And it has to be something that's improvable as well. So those are the kind of criteria that are applied in terms of testing and endorsement and adoption. And then you have all these multiple programs that are now springing up around different value-based models. And how do you get some kind of alignment across all these programs so that, from the point of view of both payers and providers and organizations that are providing services, that they're not going crazy with all the different, measures that are coming at them. And then you have to update these things over time to see if they're still working, if they make sense, if there's been an improvement. And so there are different players in the quality measurement industrial complex, so-called 6 Ps, so to speak. There's evidence developers, which are researchers announced in the NIH, PCORI, AHRQ. There are guideline developers, which are mostly professional associations. the American Psychiatric Association, American Psychological Association have efforts around developing guidelines. The measure, but then you have to translate those guidelines into actual measures. And so there are groups that do that. For example, the National Committee for Quality Assurance, the Joint Commission, the Centers for Medicaid Services. And then also they act through a series of contractors, researchers, and also sometimes employ, have projects in conjunction with the professional associations. And then there's measure endorsers to say, hey, this measure is okay for widespread use. And that includes what used to be the National Quality Forum, which was, but now that has been taken over by other groups that are, that conduct the endorsement process. In this case, it's Battelle that's been taken, that has won the contract from CMS. And then there's the overall measure application partnership that's actually part of the Affordable Care Act. When they passed the Affordable Care Act and they introduced some of these value-based payment models, the Republicans were concerned about the government telling doctors what to do. And so they required that there be a multi-sector, non-governmental entity to review all of the measures that CMS would propose for any of the value-based payment programs. And I was actually the first. There had to be a behavioral health person on that committee, and I was appointed to that and then became the chair for 4 years. And so that is also part of the endorsement process, especially for formal Medicare, Medicaid measures. And then you have the users, who's actually using it, which includes CMS, other health plans, provider organizations, the media, you see reports of that. And ideally, the public will make decisions about, I'm going to go to this group or that group because I see they're performing better. That's the ideal goal. So the other problem, another problem, 4 to 10, is the fact that we have siloed and non-interoperable data sources to actually have similar data coming. So we have data coming from primary care, we have data coming from medical surgical specialists, and then we have behavioral health clinical data. And they're not necessarily aligned in actually providing, all of the data, parallel data, similar data, in the same way. And then we also have the breakdown of sort of different systems of outpatient care versus hospital care versus other sort of clinical organizations like CCBHCs and other kinds of groups. So getting them all to collect data in a similar way and report it in a similar way is difficult. And even with claims data, which seems to be an easier thing to access, you have the difficulties of carve-in payers and carve-out payers, and actually, again, getting kind of coordination around that. And this has also been made more complex by the privacy barriers put in by HIPAA and CFR Part 2 in terms of specifically behavioral health and substance use. And we also have limited interoperability across different ontologies, whether it be DSM and ICD versus using SNOMED or LOINC, or other types of sources of measurable outcome data and measurable process data to actually collect that in a similar way. Some of these systems don't have adequate behavioral health coverage and detail to provide the data necessary. It's not always easily usable, especially for behavioral health organizations. And we don't really have a lot of standardized usage of outcome measures. And again, part of this has been a real lack, until recently there's been a change, but there's been a lack of investment in behavioral health informatics, from a specific way. A big piece of this has to do with the what I term EHR, electronic health record disconnect. So I don't know how many of you are familiar with the HITECH Act, but that was an act that it was over a decade ago, that provided federal funding for hospitals and doctors' offices to purchase electronic health record components. And the problem is it left out certain groups. It left out nursing homes, but it also left out mental health and substance use clinics, and it left out non-MDs. So as a result, they did not have the capital to invest in developing electronic records. And what happened was that a whole bunch of companies started developing electronic records for behavioral health, but they were kind of late to the market, and they were sporadic, and they were competitive, and they didn't necessarily weren't necessarily standardized. So a lot of this more specialized EHR market for behavioral health were kind of one-offs, or they're certainly less able to integrate with things like Epic and so on. And then you also had the privacy barriers, which also made it complicated. The other problem that is important is that the need for risk adjustment. And that is that if we have a safety net providers that are seeing people that are especially worse off, whether it be because their symptoms are more severe, or whether it's because they have greater degrees of social determinants, that's a harder job for them to get people better. Without having some kind of capacity for risk adjustment, you're essentially penalizing them, and really maybe supporting inequitably care systems for more severe patients, for more socially deprived patients. And so how do we deal with that? Because you need to have the data to do risk adjustment. You need to have data about severity of illness. You need to have the data about social determinants. And the other problem is that there's kind of a potential gaming of it too. And I don't know if you've seen some of the reports about Medicare Advantage for companies that have been upping their comorbidities, potentially illegally, in order to get a higher payment rates. But these are the kind of things you have to worry about when you are developing these kind of value-based payment models. And then once you have the data, it actually says, oh, these are the people that need more help with whatever. How do you actually take action to be able to actually improve their care, see them more frequently, provide more evidence-based types of approaches? Because we have a whole fragmentation across all these different types of providers, whether it be behavioral health specialists, primary care providers, other medical providers, linking what's going on in outpatient care with what's going on in hospital care, and the delivery of social services as well. And then you have payers that are also many different types of payers, not a single group that has a capacity to gather these data and take action based upon the data. And then the purchasers. So both from the point of view of public purchasers, whether it be state Medicaid agencies or whether it be CMS from a Medicare point of view, or whether it be employers, are they keeping tabs on the quality of care that the people they represent are getting? Because they have to put pressure on the providers in order to meet those standards. And then it goes on to other Ps, whether it's policymakers at national, state, and county levels, and also our population level kind of thing. I'm looking at it not only from the point of view of individual providers or individual health plans, but what's going on nationally. And then if I'm a patient, I want to know what's going on too, if I'm going to seek services. I want to be able to have access to data and actually make decisions based on that. And the problem that comes up is, who is the accountable entity? What is the accountable entity in terms of actually gathering the data and applying that data for improving care? Another big barrier is the extent of the behavioral health workforce. Right now, we have an extensive shortage of providers. It's really hard to find people that are willing to accept new patients into their practice. It's hard to get into a hospital. It's hard to get into a behavioral health setting of other types. Now, the other part of it is we have a lot, in many cases, in the behavioral health area, which is distinct from other parts of medicine. Although there are different types of concierge medicine that has a high rate of payment that you have to give in order to get access to their care. But with behavioral health, there's a huge industry, a cottage industry of solo practices, people who set up practices and converted their garage or their basement or whatever, or their offices to see patients without any kind of significant infrastructure for their office for reporting data, often not having an electronic health record available, aren't really applying measurement-based care, where they're actually collecting this data, even not in a reportable way. And they basically, have a limited capacity or desire to respond to value-based payment models. And the biggest issue is that they often opt out of insurance, have cash-only practices, and really have nothing to do with options for value-based payment. We published a paper several years ago showing that 65% of psychiatrists don't take Medicaid. 54% don't take Medicare. That hasn't changed very much since we published it. And then the other thing is that there are ways by which we can be more efficient in providing care, because what I might term interstitial providers, whether it be care managers, case managers, applying the collaborative care model. But there's a whole Tower of Babel, if you will, of the different categories. I run this National Health and Aging Policy Fellowship, and we have orientation sessions early on for the fellows, and we bring in different panels of people. We bring in one focused on state policy, and the National Council of State Legislators said that their biggest problem is having some kind of standardization of behavioral health providers across states for their licenses and certifications. When you look at it, and so that's a real problem. And so we don't have those national, standards. And the ninth point is that the incentives are often too small. Only a small number of value-based programs actually include behavioral health measures and apply them for incentives. And when they are included, it represents a very small proportion of the potential bonus or the potential penalty. So it's not really, incentivizing sufficient. And when you think about, if you were a payer or you were sort of an organization providing it, you have to do a lot of work to do a good job on this, and a lot of making connections and so forth. And what you find is it's often easier or cheaper to take the penalty than fix the problem. And so that's number 9. And then number 10 is a lot of the incentives for the organization to adopt a value-based payment model is that there's a notion that there's a cost offset when you add behavioral health to an overall healthcare system. And that is true, and Ken has been involved in some of the studies that look at this. But oftentimes, if you look at the actual studies, the cost effectiveness has shown savings at a societal level when you build in things beyond direct healthcare costs. And when you look at the well-designed demonstrations of reduction in direct healthcare costs, it's not as much as you think. And the investment you have to make to improve care, again, may not, takes away from the incentive that you might get from a value-based payment model. And those that have shown a demonstration, it's usually when they focus on very specific high-risk populations. And so the other people get less attention. There was recently, the University of Pennsylvania recently did a study, Matt Press, who's one of my mentees, did a study where he basically implemented throughout the system collaborative care models, and also built in a way to automate the billing for collaborative care, so that they're able to do it system-wide. And what he found is that they were able to actually provide, universal collaborative care for depression across the board. And they were able also to get payment for that. But which basically, did not give them any profit from that they did not drop overall healthcare costs, but they kept it even by getting the payment model. So it's not something that we are incentivizing sufficiently, either because through the process of meeting the criteria for avoiding penalty or for getting incentives, or in terms of just seeing a overall reduction in healthcare costs. So there are some strategies and solutions going forward to think about that I think are partly related to expanding investments, expanding supply, improving equity, expanding incentives, and establishing the concept of shared accountability. So let me get a little bit about it. So investments, we need to make more investments in behavioral health informatics, on quality metrics development, and ultimately demonstrating their impact, and testing new models for collecting data and applying data. And some of these may be sort of digital approaches that can be more easily used. And that's going on now, as you probably see around you. We also need to think about, are there ways by which legislation can be introduced to make up for the high-tech exclusion for behavioral health providers and for behavioral health systems? And then to think about how we might be able to provide technical assistance for practices and organizations to be able to move into the capacity to provide that value-based care. So we need to think about how we can expand supply. I mean, to think about expanding the production of psychiatrists and other licensed professionals, that's going to take, decades. It's not going to happen overnight. So to think about how we can expand some of the integration models like collaborative care, to apply some of these new technologies, digital apps, other kinds of things. And also to adapt innovative models from other countries, from other areas. So I don't know how familiar you are with the United Kingdom's program for improving access for psychological therapies. But basically, they developed a set of IAP centers for training people in evidence-based treatment programs. These are people who are largely come out of college, a baccalaureate with a degree in psychology. And they go through testing and training and testing in the ability to provide cognitive behavioral therapies. And it was developed by an economist who actually was friends with one of the prime ministers in England, who one night over dinner said, if we had more people getting cognitive behavioral therapy, we'd have a more productive nation. And so they started this, and so they have basically created an army of people, and they're connected with, and they're overseen by an online supervisory group. And they're connected to primary care providers. And so there's a back and forth, so that there's much greater access to psychological therapies in the UK. In the military, and we're part of a RAND report to look where there's been some behavioral health techs that have been trained and developed in the military to actually do task sharing and other kinds of things. That also has improved efficiency in the military. But I think really what needs to be done is we need to develop a more national set of standards, going back to what the National Council of State Legislators, that talks about the typology of who are the providers in a standardized way, that develops an ontology of tasks, and how we develop an infrastructure similar to the IAP program for supporting and developing people to do these things. Under the previous administration, actually, there was a beginning of that with a big workforce initiative that actually included behavioral health by the Biden administration. That's obviously not going to go anywhere. And then there's also the longer term, again, questionable about where this can go anywhere, of sort of expanding incentives and loan programs, for generating this workforce. We also need to think about improving equity. Again, something controversial right now in government, but part of it can be done straightforwardly with better measures of social determinants of health and more collection of those data. And the other thing is, rather than do pure risk adjustment, where, again, what I was talking about before in terms of just adding more comorbidities, to actually pay more for improvement of measures if there's a disparity population. So that may change the way the incentives are framed. And also, I think, and it's something that we've written about, is that people with serious mental illnesses die 10 to 20 years earlier than the general population for a variety of reasons. And to think about creating a disparities category for people with severe mental illnesses. And then finally, to expand incentives that, we only spend about 5% of overall US healthcare costs on behavioral health. And in some ways, having better quality measures will be able to get more public support and confidence in the assessment of the value of behavioral health care. Because there's a perception that, the people are in this, forever and they don't get better and that kind of thing. But if we actually have measures and we're promoting that, that could actually inspire more support. And I think that also stronger regulatory actions. I mentioned before the sort of enforcing of parity can also push these things forward, and that will amplify the financial incentives. Something relatively new, and this is something is that I gave this similar to this talk to actually grand rounds at CMS last year, and initially they were kind of annoyed with me, but they actually responded, and I actually met with them several times on this, where they actually developed a value-based payment model called Innovations in Behavioral Health, and it was different than what I thought it would be, but it actually makes a lot of sense. It's basically kind of reverse integration. Instead of putting behavioral health in primary care, put primary care into behavioral health, especially for people with moderate to severe behavioral health conditions. And in September, they had a deadline for states to Medicaid agencies to apply, and I worked with New York State to actually apply, and we actually got it. And we're in the process of establishing it. This is what was in the fact sheet in terms of what was expected from the program. So this is, it's kind of like a notice of funding announcement from NIH, but this was different because it came from, it would be the state Medicaid agency applying for it and so on. And just recently they came out and they had these state agents, Medicaid agencies were selected to participate. So New York's going to be involved in it, Michigan, Oklahoma, and South Carolina as well. I don't know if California applied for it or not, and so we'll see how that goes. We're in the process in New York to actually, further develop this. So anyway, these are the top 10 reasons, and why don't I stop there and see if there's questions, ideas?
Thank you. And yes, there are questions in the chat. We can
Okay.
do those, and then also in the audience. Let me put these up here. So there's a series of questions. So first, from Eric Chung, one of the barriers to comparing measures, performance, value-based care between institutions may be the lack of ability to perform risk adjustment between different populations, which you've commented on some.
Mm-hmm.
In my experience, the CMI does not currently seem to be a valid risk adjuster in behavioral health, nor is it really applied in discussions about value-based care or patient outcomes. What is your view of this?
Well, I think that, there needs to be a lot more work around risk adjustment. And I think that, it's a mixture of both clinical aspects of the, that the patient has, but also, as I said before, so sort of the social determinants that are involved. And to have, it's complicated to actually combine those two in many ways. But I think it might be one way of dealing with that, as I said before, is that if you identify just overall a population that is more at risk, to provide a higher payment or higher incentives for the same level of improvement. Mm-hmm. And so that one would be one way of getting at this, in a fairer way.
Okay. And the second question from Diana Lee Luxembourg is, please describe the societal level improvements in the collaborative care method. What specifically improved in an area? Well,
I mean, the collaborative care model is based off the Ed Wagner's from Group Health of Puget Sound chronic illness care model. And if you think about it, there are sort of different steps along the way, from screening, and you never say screening without follow-up, screening and follow-up, patient engagement, standardized longitudinal measurement over time, adjustment of the strategies and care based on, and with intensification based on a menu of intensification strategies. And the key underlying, to my mind, the key underlying principle of both collaborative care and chronic illness care is what I term ruthless follow-up. Not letting people fall through the cracks. That's one of the problems. A number of years ago, we did a study looking at, characterizing episodes of outpatient care for behavioral health. Guess what the modal number of visits are for somebody who gets an outpatient care episode? Anybody? Yes, 1. And the median is 4. Now the mean is higher with people getting psychoanalysis and so forth, but that's.
Yeah. And if I could just make a short comment on that, because I've done a lot of studies in
Yes.
collaborative care.
Yeah.
So we found that by implementing a model that includes the community as part of collaborative care, so there's like community health workers and so forth, and dealing with depression, that can reduce homelessness, that can reduce arrests. And so some of the social outcomes that reduce the social costs as well as healthcare costs.
Right.
And that's still noted by the Cochrane Collaborative Review as the most evidence-based in any area of health for the added value of community in collaborative care. So just a small note.
Yeah, absolutely. But
it's your talk.
No, absolutely. No, I agree with you. The problem is, it's, to what extent are the health plans accountable for this? And do they get rewarded in some way if this happens?
Yeah. And then Bowen has a comment, Bowen Chung, thank you for your talk, and there's so forth. And then he says, what are some of the metrics for quality that are validated? And can you just comment on whether these efforts are a good place to partner with around developing quality metrics? And he's commented specifically the state Medicaid programs, CCBHSs, like in Missouri, Tennessee, Texas, Vermont. Some of your metrics are focused less on what are we traditionally consider to be quality, more on timelessness and so forth. Anyway, some comments on metrics for quality.
But more on what?
But more on timeliness.
Yeah.
So
it gets to the, I personally feel that, going back to the Donabedian framework of structure, process, and outcomes, you need to have a balanced portfolio of those 3 things. You need process, but you also need outcomes. And that's part of it. And the problem is, a lot of these programs that are now developing sort of metrics for outcomes are just doing it for reporting's sake. But the point of measuring outcomes longitudinally is to influence clinical decision making. That's the main point. And oftentimes it's simply, we're just reporting it, we're not actually using it.
Yeah. Should I keep going, or should we go to the out to the audience? And I'll come back. Yeah.
Okay.
I have a question that might be best left to the end, so you can hold on to it if you'd like. This is amazing work, and I guess the elephant in the room is what traction, if any, is there with the current administration? So I guess one form of that question is there anything that we may not have thought of that could be captivating for the current administration? Number 2, are there elements that might have bipartisan support, in Congress or elsewhere, or with red states that are looking to do?
Well, I think that, I think one could make a good case, whether it be attended to is another issue, about improvement in efficiency. That it actually enables people to figure out, you're incentivizing organizations to actually be as efficient as possible, and to utilize this data for decision making, and it incentivizes them to do that. So I think that would be the case to be made. The secondary case is we'd be making more people better, but that seems less important right now.
Question. So there's the quality measures and there's the value. Are there examples internationally where they're successful with value-based care either because of really great quality measures or maybe completely independent of good quality measures?
So, we really don't, we are the ones who are sort of in this place where, we focus on value and cost,
Right.
but don't actually do it.
Yeah.
That's, other countries, most people have government-run healthcare. And it's an internal process and they're able to administer lots of internal processes. I haven't seen any clear models of, sort of other countries having value-based programs per se, because they often don't have a private sector that they're incentivizing. Yeah.
But there are some that are tracking outcomes.
Yes,
Like
yes.
Australia, UK.
Right,
and
absolutely.
so
Yeah.
forth.
So they are tracking outcomes and they're making it part of the culture. And I think that's in some ways the challenge we have is that, we haven't made it part of the culture.
Okay, and then going back to the comments here, given UK's behavioral health results using paraprofessionals, wouldn't that in fact decrease costs and improve behavior? So that money is not the answer, but community care, which is
Yes,
kind
yeah,
of related
yeah.
to the one I mentioned.
Yeah, the IAP program is actually utilizing a broader range of potential people in the workforce, and being specific about what are their tasks and how do you train them, and making them connected with the larger group that's working, with that population.
Yeah, and then Donna Ames, anyone working to compare BHA versus Medicare in terms of collaborative care, BHA has generally been seen as pretty cost effective versus Medicare.
So, a number of years ago at RAND, we had a project to evaluate the VA medical care system with regard to behavioral health. And we actually published several papers on this, including one that showed that the VA performed much better than the private sector overall. Now, whether, we didn't compare it to, specific value-based payment models, but, but we did, compare with overall national measures.
Yeah. Any final questions? There we go.
I just have a good question. You mentioned the IVH models where the severe psychiatric conditions can be managed alongside less severe medical problems. What does IVH stand for and how?
Innovations in behavioral health. Yeah. It's it's something that's a model that the Center for Medicare and Medicaid Innovation sort of put forward, and these 4 states are now going to be implementing it.
Thank you.
Yeah,
You
there's-
see some
there-
of that online, right? Isn't there a sort of an explanation of?
Yeah. It should be online still. I mean, initially it was online for the, for the
To
notice,
apply for,
to apply
yeah.
for it. But yeah, I mean, I've had discussions with CMMI in a number of instances. There are some concerns about it and that need to be clarified. Like, for example, the population is defined as moderate to severe. And what is moderate? It wasn't officially defined. Another problem is, so they're going to be building, quality measures into it. But the problem is, since the focus is on the, the non-behavioral health problems, there are thousands of potential measures for those things. And how are they going to decide which ones?
Standardize it.
So,
or-
yeah, so that's, so those are the, and I've had discussions with them about that.
Okay, so thank you so much, Harold, for a really wonderful presentation. Yeah, and let's hope we go forward with
Yes.
having better behavioral health care, right? For
Yeah.
all.
That's the hope.
Yeah. All right,
Okay.
thank you.
Thank
all.
you for inviting me.